All right. I think we're ready to get started. So, welcome everyone to our weekly orthopedic surgery grand rounds. And today we have the honor of having one of our faculty members, Dr. Coleen Sabatini, here to present to us. I have to say thank you to Dr. Sabatini for stepping up and having interest in speaking to us today after an external speaker was not able to make it. But we really appreciate it, and I think it's going to be a great talk on really exciting work. So Dr. Sabatini is a professor and vice chair of academic affairs and health equity for our Department of Orthopedic Surgery here at UCSF. She did undergraduate at UCSD, where she studied biology as well as dance, and then went to Harvard, where she did medical school and also received her master's of public health. After her time at Harvard, she did fellowship at Children's Hospital Los Angeles, and then joined the faculty here at UCSF. Her clinical practice is based at Children's Hospital of Oakland. She sees and treats a wide variety of pediatric orthopedic conditions. She also splits her time between here and Uganda, where she has an active clinical practice. And her work in Uganda is really focused on capacity building, education, research. She has helped develop a pediatric fellowship in Uganda. She has a number of ongoing research projects where she serves as PI and as a important collaborator for cross institutional work between here and Uganda. She is also the chair of the international committee for the AAOS. She's on the board of directors of POSNA, as well as the J. Robert Gladden Society. She serves as a director of the Centers for Health Equity in Surgery and Anesthesia here at UCSF, and clearly has done a lot and continues to do a lot in promoting health equity both here and around the world, locally and at multiple other societies. So today, Dr. Sabatini will be talking about research in Uganda, and thank you again for doing this, and look forward to your talk.
Thank you, Jeremy. Thank you to Dr. Lansdowne for memorizing that. And I do want to send thoughts and prayers to our visiting professor who was not able to be here today, Dr. Dunbar, and hope that all is well with him and his family. So I am pitch hitting a bit today, so please forgive me if this isn't the smoothest of all things. But I am going to talk today about a very specific area of research that I've been involved in for the last 9 years. And this is titled At an Intersection of Public Health and Orthopedics, Developing a Research and Advocacy Program to Address Injection Injuries in the Children of Uganda. And some of you might have heard snippets of this over time, but hopefully this will give you a bit of a more in-depth sense of what this work has been. I have no specific financial disclosures that are relevant to this talk in terms of financial interest, but I do want to acknowledge that I've had some research grants through POSNA and the department that have funded some of these projects, as well as Nth Dimension scholars who have contributed to this work as well. So I want to acknowledge all of those entities. From the Eamon Abbott lectures that we had a couple weeks ago, where we had a session on global health, I'm going to talk a little bit about that just to frame this conversation, that currently there are 5 billion people that lack access to safe and affordable surgical care and anesthesia in the world. If we were to address the unmet burden of surgical disease, we would need to do 143 million additional surgical procedures, most of them in LMICs, in order to address that. There are currently 1.7 billion children and adolescents that don't have access to surgical care, and less than 3% of the pediatric population in low-income countries and less than 8% in low-middle-income countries have access to surgical care. So 30% of all morbidity and mortality worldwide is related to surgical disease, and that's 4 times more common than HIV, TB, and malaria combined. This is not new. So even though the Lancet Commission report came out in 2015 that highlighted all of this, this was the then Secretary General of the WHO in 1980 saying and acknowledging that surgery has an important role to play in primary health care and that people need access to skilled surgical care at first-line referral hospitals. And the lack of surgical care was the most serious manifestation of inequity in healthcare. And again, that was more than 40 years ago that was defined and explained, and we've made very little headway since that. Part of that is because our funding priorities are probably not where they should be. Again, if you look at infectious disease, the vast majority of global health dollars go towards infectious disease. yet total surgical avertible deaths in cardiovascular disease account for much more death worldwide, yet have very little to no funding available to them. So I'm not saying we should take money from infectious disease, but I'm saying that we need to expand that pie of resources and focus on surgical conditions as well. This is just another visualization of that huge population that lacks access to surgery. So of those 2 billion children, more or less, that lack access to surgical services, we have more than 6 million deaths every year related to surgery, and these can be congenital disorders, injury, and cancer. And that lack of access is both insufficient surgical and anesthetic workforces, inadequate infrastructure, equipment, and supplies, and multiple factors such as poverty, distance to health facilities, lack of emergency transport services, which is a huge problem in lots of low-income countries around the world, and a general lack of awareness about surgical disease, that people don't know that you actually need to get certain things treated surgically in order to sustain life. Talked about this briefly at Inman Abbott, but my personal work sort of started as a public health person after college. That is going to be important for you to understand as I talk about the topic of today, which is very public health based. My work when I was a medical student and a resident was really in the Dominican Republic and the Dominican community in Boston. And then I came here in 2010 really because of the global health history, particularly in orthopedics, through the leadership of Rick Coughlin and IGOT, as well as the fantastic partner that Mohammed Diab was and has been through all these years, and really the institutional commitment of UCSF to health equity. And my first trip to Uganda was in 2013. I started a project there in 2015 and have been about 20 times over these last 9 years. And then in 2019, in order to focus more on this work, changed my clinical practice up here so that I could spend at least half my time doing that work. As we've talked about, really an emphasis on capacity building, research, education, advocacy, and patient care. And when we talk about global pediatric orthopedic surgery, we're talking about a range of traumatic injuries. Here we really treat, in the United States, acute injuries. But in so many places around the world, the acute injuries don't come to orthopedic care. The chronic injuries do. So in Uganda, for example, the vast majority of musculoskeletal conditions that are traumatic in nature are treated by bone setters. And so are septic joints and osteomyelitis. So we'll see a patient several weeks to months after something has presented. And often the way to treat it is much more complicated than had they come initially. There's a huge number of congenital deformities. Clubfoot is in abundance, and other foot deformities, lots of limb deficiencies and deformities. Hip dysplasia, not so much in Uganda, but in many places, depending on how babies are carried. And then certainly a significant number of neuromuscular conditions, although because preterm babies' lives are not as easily sustained in other countries as they are here, we don't tend to see the more severe GMFCS 4 and 5 cerebral palsy patients, for example, because many of them die soon after delivery. And there's a huge host of acquired conditions. Nutritionally deficiencies lead to a number of angular limb deformities. There's a huge population of Blount's disease, infantile Blount's disease in Uganda that we're not exactly sure where that's coming from. It's not all nutritionally related, and it's not weight related either. And then osteomyelitis and septic arthritis, which again are far more severe in presentation there than they are here. So here we might see a child with acute osteomyelitis. They get antibiotics and they go on to have a normal, fabulous life. In Uganda, it is not uncommon for a child to come into clinic like that lower picture, which is basically their tibia extruding from their leg because it's a full-length tibial sequestrum that's been extruding through the soft tissue for several months. And then, of course, a significant amount of spine deformity, often most of which is actually related to TB, so Pott's disease, not something that we see too often here. So over the years, I've developed a research program focused on a number of these things. And what I'm going to talk about today is really malaria-related, communicable disease-related orthopedic conditions related to the use of injections. So to frame this a bit, Uganda, which is the place where I have focused the majority of my global work the last decade, is currently a country of about 45 million people, with the average life expectancy being 69 years of age for women and 62 for men. That compares to the United States, where our life expectancy rate is about 79 years for both men and women, although that did go down a bit with COVID. The under 5 mortality, so children dying under the age of 5, is 45 out of 1,000, and that's 6 in the United States. 27% of males and 23% of females die before the age of 15. A huge population lives in village areas, so 85% live outside the cities. It is a low-income country by World Bank classification, and even though some of the countries around it have become low-middle-income countries, Uganda has remained in the low-income bracket. And undernutrition is a very common problem, with a third of all children in the country under the age of 5 considered stunted or malnourished, and about 45% of the deaths of children under the age of 5 are related to malnutrition. The conditions that I study there are, in fact, associated with malnutrition because of the small muscle bulk, which we'll talk about in a little bit. A lot of people don't know, but Uganda is actually hosts the largest refugee population in all of Africa and the third largest in the world. So it takes on a huge amount of burden from the surrounding countries, specifically Sudan, South Sudan, and the Democratic Republic of Congo. And there's a whole refugee population with a variety of untreated musculoskeletal conditions across the northern and eastern borders. And there's over 50 tribes and over 70 different languages that are spoken in the country. Despite the statistics that I showed you, I do want to highlight that Uganda has improved significantly over the last 30 years. That is the under 5 mortality rate that has decreased significantly from close to 200 in 1990 to its current rate. The population is forecasted to grow significantly. So again, in 1990, it was less than 20 million. And by 2100, which is actually not too long from now, it seems, it'll be close to 140 million in this very small country. And currently, the blue line is what the population is in the country. So you can see a huge portion of the population is children. With some of the family planning and interventions that are expected over the next several decades, we do think that that will become a more aged population, which is what happens as you move, I guess, more from, I don't like the term developing country, but as you move up in terms of development, the age usually tends to increase as the birth rate decreases and life expectancy increases. So I share that only to frame this conversation about the conditions that we're going to be talking about and the context in which they're occurring. Again, this is a slide that I shared in part at the Inman Abbott talk, but if you compare Uganda to California, Uganda is about 60% the size of California, but has more population. So about 46 to 48 million people now in Uganda and about 40 million in California. In Uganda, greater than 50% of that population is under the age of 18. So you have more than 21 million children. And in California, we are an older population. So we have less than 10 million under the age of 19. I can't get data. That's the direct comparison of the under 14 year range. And then just in terms of orthopedic populations, right, we have 2,400 in general orthopedic surgeons in California and about 80 in all of Uganda, with 134 pediatric orthopedic surgeons in this country, and 2, my friends Judith and Francis, in Uganda. So really 1 pediatric orthopedic surgeon per 10.5 million children. So that is why we have started a orthopedic fellowship in Uganda. And so Judith is the one on the right, but the other 3 are our current fellows holding Dr. Diab's book. Thank you, Mohammed, for donating. And hopefully we will continue to increase the orthopedic workforce over time. So let's talk about malaria, because that's a very keen orthopedic topic. Anybody know what that is? It's an Anopheles mosquito, as we like to call it, mosquito. In case you don't remember, malaria is a very common infectious disease throughout the world. It actually used to happen in the United States, but through systemic eradication programs into the 1950s and 60s, malaria sort of went away in America, in the United States, but still is really across sort of the equatorial part of the world, which we'll talk about in a second. The Anopheles genus of mosquitoes is the only mosquito that carries malaria. And there are currently 4 types of human malaria, all Plasmodium species, with falciparum and vivax being the most common. Vivax in the Americas, falciparum throughout much of Africa, and falciparum is the most deadly. It has a very complex life cycle, which I will test everybody on later. And the important thing about that is that is what makes it both hard to treat and hard to prevent. And so I will spare you the details, but it goes through various life forms, spends a lot of time in the liver, then goes into our red blood cells, and in various places in its cycle is sort of hidden from treatment as it's replicating. Currently in the world, these are the areas where malaria occurs. So in the yellow is where it occurs in some places in those countries. And then And then in the oranges where there's abundant malaria throughout those countries, you can certainly see that malaria is very much a Africa phenomena in terms of its endemacy. And these are the current incidence rates. And again, you can see that the incidence is much higher in sub-Saharan Africa than anywhere else in the world. And unfortunately, that also translates to deaths. So in 2020, there were 241 million cases of malaria worldwide, and the death rate increased from 2010 to 2020 from 585,000 to 627,000. Africa carries disproportionate burden of that, with both 95% of all malaria cases and 96% of malarial deaths. And really, 4 African countries account for over half of those deaths. And that's Nigeria, which certainly has the highest burden of malaria, both cases and deaths, the Democratic Republic of Congo, Tanzania, and Mozambique. And then child deaths. So every minute in the world, a child under the age of 5 is dying from malaria. I share this data only because I think we are so shielded from this in the United States. We are so privileged in, our healthcare system that we don't realize that this is something that kids are dying from literally every minute. In 2021, so 1 year later than what I just shared, 247 million cases of malaria, 619,000 deaths, and 77% of those were children under the age of 5. Uganda is this country right here. And so you can see that it has not the highest rates, but still quite high rate of child death due to malaria. It is endemic in 95% of the country. It's the 3rd highest case total of malaria in the world. And there's a super high prevalence of malarial parasites in children under the age of 5. So in the capital, it's only about 5%. But if you go to other regions in the country, the malarial parasite burden is as high as 63 to 65%. So if you sample a group of children at any given time, 65% of them in some parts of the country will actually have malaria at that time. And so leading cause of morbidity and mortality in the country for a long time. It accounts for a huge burden on the healthcare system. So up to 50% of outpatient visits are related to malaria, and a number of their hospital admissions, and up to 20% of the deaths, and not counting the people who die outside of the home that are never recorded. So this is just an endemic sort of map showing you where all the prominent rates of malaria is. And it's really just outside of the capital. Pretty much everybody else has a huge malarial burden. And obviously, malaria has been a huge topic of conversation in the public health world for a long time. USAID, the CDC, others are very involved with malaria eradication around the world, focused really on bed nets, and then internal, like in spraying in the houses. And we've seen a decrease, but there's still a huge number of children, as you can see, dying from this condition. And then just a quick blurb on healthcare in Uganda. So it does have a national health system, but does not have national insurance. So people do have to pay out of pocket for much of their care. There's 2 national referral hospitals, with Malago being the biggest and the most well-known, and then 14 regional hospitals and a huge number of district hospitals. But importantly for our conversation, 50% of the healthcare is provided by private hospitals and clinics. And just to further confuse you as to what I'm talking about, we're going to talk about quinine for a second. Quinine, otherwise known as quinine, depending on what part of the world you are from. In case you forgot your pharmacology from 1st or 2nd year of medical school, well, this is from the bark of the cinchona tree. It's been a mainstay of malaria treatment for over 400 years and can be given a number of different ways, which include POPR, intramuscular, and IV. And really in the 1940s was when chloroquine came into being, but had widespread resistance by the 1980s. And during this whole time, though, quinine continued to be an excellent agent in the treatment of malaria. In 2006, the WHO dropped quinine as a first-line agent, but has continued to be used widely around the world. And the artesunate medications really became the standard of therapy for falciparum malaria. So if you go to someplace in the Americas, you might still go on chloroquine, for those of you who have traveled. Chloroquine is totally useless in Africa. Most of the falciparum is totally, resistant. Thank you, to quinine. And so artesunate has become the medication of choice, but there's serious supply chain issues related to artesunate. It's 20 times more expensive in most places than quinine. And so quinine has really continued to be an issue and an item of malaria treatment. And there's very little resistance to quinine despite its decades of use. And we'll talk about why that's important in a minute. So you're all probably wondering why in the last 20 minutes I've been talking about malaria. And this would be why. So this was my first trip to Uganda in 2013. And I was standing outside a hospital in the middle of the village of Kumi, Uganda. And I saw this group of children playing football. And I, being the good pediatric orthopedic surgeon that I try to be, was very struck by their very awkward gait, right? So they have very externally rotated legs, particularly the tall boy and the one in green. You see them running very externally rotated and just very awkward. So as I was standing next to one of the physical therapists from the hospital, I was like, what in the world is wrong with these children? And she said to me, gluteal fibrosis. And I had no idea what she was talking about. And so they brought in a little group of kids, some of those kids that were playing soccer, and they brought them into the physical therapy room, and they had them all squat. And they all squatted like that with their legs frogged apart. And I was like, okay, what are you trying to show me? And they're like, squat again with your knees together. And all the kids tried to squat, and none of them could keep their knees together. They all externally rotated. So I found myself thinking, what in the world is making a child squat like that? So this is a kid, again, trying to keep his knees together, but goes into a full squat. And that's how he's like a perfect ballet second position. My heart was aflutter with what his turnout would be. But alas, he had significant hip pain and had not been to school for 2 years because he couldn't fit in the desk at school. So I was very struck by what in the world is this gluteal fibrosis. That afternoon, I went across the road to a different hospital in the same village, run by my dear friend, John Akure, who has this Kumi Orthopaedic Hospital. And he was like, hey, Coleen, come look at this kid. And because I had just been expounding about how I knew nothing about gluteal fibrosis and just met 100 kids with gluteal fibrosis who were there for surgery. And he was like, I have this for you. And so what you can see, hopefully, is that this child has a steppage gait. He was born normal, had a normal gait. 3 weeks prior to this presentation, he got an intramuscular injection of quinine into his left buttock and had acute onset of significant pain and a foot drop. And I was like, what is this? Well, this is post-injection paralysis. So here I was in one day looking at 2 different orthopedic conditions that were related to injections. So one is gluteal fibrosis, one is post-injection paralysis, both leading to orthopedic disability. And I was seriously blown away because as somebody who had been a public health person who then crossed over to orthopedic surgery and wondered if I would ever find something that combined those 2 things, here I was looking at orthopedic disability and public health in action, and that is where I was supposed to be. And so this for me was a major life-changing moment because I'm standing in a field looking at something, this whole group of kids, looked at this other kid with post-injection paralysis and was asking them like, well, what are we doing about this? What are we, what kind of, have we done any research? And they were like, we can't do research. We don't have any funding. We don't have any time. We don't know how to do the research, but we'd love to help if you're interested. And for me, that was my moment. So in 2013, when I first saw that began my commitment to Uganda and to this work, specifically around the very unsexy conditions of gluteal fibrosis and post-injection paralysis. So let's talk about those. So this is clearly the buttocks of a small child. There's a gluteal cleft there, and all of those other things are fibrotic infiltration of the gluteal muscles leading to that scarring and atrophy that you see. It is not only cosmetic, because people do, in fact, care about what their butts look like. Much more importantly, it is actually very functionally disabling. So these kids get limited hip range of motion, limitation of function. And if you ask people, what is this caused by, the sort of explanatory model in the area is that's due to excessive intramuscular injections into the muscles. And quinine is what everybody blames. And that's why I talk to you about quinine. So we get this muscle contracture that gives us limited flexion and adduction of the hips, so they cannot sit or squat. You might not think that sitting or squatting is that important, but in a culture where everybody squats around the fire to eat, they squat at the toilet to go to the bathroom, because in the villages, there's pit latrines. There is no toilet. If you cannot squat, it is phenomenally disabling. They have an awkward gait, as you saw when they were playing football. It's particularly noticeable when they're running. It's usually bilateral because the injections are bilateral, and it is, again, significant muscle wasting and atrophy. Usually it's diagnosed in school-age children because we think the cumulative effect of the medication over time that causes that fibrosis takes a few years to onset. So in standing, they cannot bend down to reach objects on the floor. And that is particularly important since, again, 85% of these kids live in the village where agriculture and subsistence farming is the way the family survive. So to have to bend over without actually being able to bend over causes significant strain on the low back. So there's lots of hip and low back pain purported in these kids. And really gluteal fibrosis, because I knew nothing about it in this moment. I went to the literature and I looked, and certainly it has been published on widely in the 1970s in particular. And you can see all of those countries in which it has been reported, but really nothing since the 1970s. On physical exam, that's Norgrove Penny right there, who is the person that first got me started in Uganda. He's a pediatric orthopedic surgeon from the University of British Columbia. So this is that child that I showed you before. We attempted to flex up his hips, and you can see his entire pelvis just lifts off the table because there is no excursion through his hip joints. And he has difficulty sitting in chairs. So you can see how he sits in the chair. He got kicked out of school 2 years before because, again, he was taking up too much room in the classroom because he couldn't pull his legs together. Why does this happen? So this is what as I was reading all of this, literature, all anybody talks about is that there is gluteal fibrosis. There's not really a lot of research into the etiology. So sort of the, various theories could be that there's microabscess formation in the setting of substerile technique with multiple intramuscular injections that causes this scarring. You can have particular medications perhaps inducing fibrosis. There can be mechanical disruption of the tissue planes as you're putting large volumes of injection into the muscles. So you're getting sort of insufflation and then contraction of the plane. Perhaps that gives you this fibrosis, or it can be a combination of all of those things. Why did this matter, right? So again, this is not just a cosmetic issue. It's not just an abnormal gait issue. These children report pain. They have an inability to carry out their activities of daily living, particularly their house and agricultural work. And they have difficulty going to school. So they get teased. Uganda is much like everywhere else in the world where children can be quite cruel. And if you're different, it's often because either, your family did something and so you're cursed, or, the witches got you, or there's a variety of explanatory things, none of which are good. And no child wants to be subjected to that. Some of them aren't allowed to go because they take up too much room, as I've said. And then many of them reported that they have pain walking long distances. So they would go to school like every other day in order to rest on the alternate day because it hurt too much to walk, because many of them walk several kilometers to school every day. I can show you countless examples of these kids. So all of them have, again, when they flex their hips, they have an abduction contracture. They cannot adduct, and they cannot flex well at all in that adducted position. They can't squat well, and they can't sit. They can't really side sit very well. So this person is being held up by one of the physical therapists. His hip joints move so little that if you lift up his arm and Francis wasn't there holding him, he would just fall over. So many of these kids report that they have to either lay down on their stomachs to eat or stand up because they can't sit and hold the plate and the utensil at the same time. Then this doesn't go away, right? It doesn't all of a sudden, the fibrosis doesn't dissolve into adulthood. So this is a woman I met a couple years ago who had come into one of the other hospitals that I'm at, also with gluteal fibrosis, who was concerned about childbirth, because she couldn't flex her hips up enough to get into a position of delivery. And so that's a whole nother area that we have concerns about now as some of the young girls are becoming sort of age of motherhood. How are they going to deliver? And there's a concern for increased risk of C-section. And when you don't have access to surgical care, needing a C-section is a big deal. So what are we going to do about that? Interestingly, I will also say that she had surgery a few years, about 10 years prior, because of her limited hip motion. And that was at a time when people didn't realize what gluteal fibrosis was. So they did derotational osteotomies of her hips to try to get her hip motion. And in fact, it did nothing because the problem was the butt muscles. That actually happened here in the United States. Vince Mosca out of the Seattle Children's Hospital did a case report on 4 girls adopted from China who some of them had derotational osteotomies of their hips because they did not realize that this was gluteal fibrosis and not some other, hip malalignment problem. And so China is the other place in the world where there's very high rates of gluteal fibrosis. What is post-injection paralysis? So this is an injury to the sciatic nerve from an injection. It leads to immediate neurogenic pain, hypoesthesia, and weakness or paralysis of the foot on the site of the injection. It can develop immediately or over the course of a few days to weeks. You have impairment of mobility with that high step and gait that I showed you in the video. And while recovery is possible, many kids have permanent residual paralysis, or adults. This can happen in adults too. And the peroneal branch, just so you know your anatomy of the sciatic nerve, which is lateral to the popliteal branch, is the more vulnerable one. So the foot drop can be flexible or associated with varying degrees of fixed contracture. If it's flexible, then they usually just have impaired clearance during swing phase. But as that flexible contracture becomes, or that flexible problem becomes more fixed, then you end up with this equinovarus foot. So it's much like an acquired club foot, and they start lateral border walking. And so many people come in with trophic ulcers over that area because that's not the intended weight-bearing surface of the foot. You have varus, which is secondary to peroneal weakness or paralysis. Usually the toe flexors are fine. And then the tib post sometimes is involved and sometimes is not. So it's very important that you assess tib post strength in evaluating these kids before you decide what to do for them. And then pre-treatment, usually we have, heel varus, which you have to assess. You have to know what their passive range of motion is. And again, the tib post. Pretty much all of these kids, if you have post-injection paralysis or adults, require some form of lifelong bracing or surgery. And without treatment, this is a lifelong disability. So you might find yourself asking, why in the world is this happening? Like, why are they getting so many injections? Because we, again, have the benefit of being in a place where intramuscular injections are incredibly uncommon. That's why we don't see this here, right? But in other parts of the world, injections are given as the first line of all medication delivery. So these kids are getting anti-malarials. And again, that's the context of why we started talking about malaria, because if you're going to die from malaria, it's much better to get an injection than not. And then lots of antibiotics, lots of diclofenac, which is like a big greasy substance that gets injected, and then other antipyretics. And why is this happening? Because of the burden of malaria, because people only have access to certain medications in certain parts of the country, because sometimes these surprisingly are more affordable. And there's a cultural belief that perhaps because it hurts more, it's stronger, and people want their children to survive. So they will, in some cases, pay more for the stronger, more painful medication, not realizing that they're actually doing harm. And we'll talk about that in a little bit. So in order to have a learning objective for this, we're going to have a public service announcement, which is, if you're going to give them an intramuscular injection, do not inject near or into the sciatic nerve, please. And maybe just avoid gluteal injections if at all possible. And if you're going to inject something, perhaps have it not be quinine. And so this is what I learned in medical school. I don't even know if some of you young folks, Jeremy, my dear colleague, did they teach you about intramuscular injections in medical school? Yeah. So he's about to be a fourth year here. And that's consistent with much of the young folks that I talk to these days, where they don't even teach intramuscular injections in America anymore. I did learn. They taught us the upper outer quadrant, just like this beautiful picture here shows us. Theoretically, so that's the dorsogluteal site. There's also a ventrogluteal site, which puts it in the medius instead of the maximus, which is theoretically safer. Neither of those would be helpful here in terms of preventing gluteal fibrosis. It's the injection itself given multiple times, not so much the location. And in post-injection paralysis, this is important because it's when you put it into the sciatic nerve that you have these problems. You could say, well, why not? Why do they keep giving them in the gluteal muscles? Why not give them into the quads or the deltoids? Well, then you get quadriceps fibrosis and your knee doesn't move, or you get deltoid fibrosis and your shoulder doesn't move. And there's many, many kids that I have examined in Uganda who have both quadriceps fibrosis and gluteal fibrosis. So they have no range of motion of their knee and minimal range of motion of their hip. And that is a really difficult problem to fix. So anyway, that's where you're supposed to inject. It's really interesting to me when we talk about safe injection practices, because if you look at all the literature out there that, the WHO and other organizations are putting out, none of them have anything to do with where to actually give the injection anymore. They sort of assume that people know that, and that is a bad assumption, and that leads to post-injection paralysis. And post-injection paralysis has been found in many, many places around the world. So back to this problem. So medication injections very frequent in Uganda because of the high rates of malaria and childhood mortality from malaria and sepsis. We sort of understand why PIP happens, but not really a lot of great literature on gluteal fibrosis. At the time that I started this research, there was one published article on gluteal fibrosis in Africa, nothing really on PIP in all of Africa, and no treatment assessments of either condition. And so there was really a lot of research questions in my mind regarding these iatrogenic injuries, and a tremendous opportunity to look into these problems, both from an epidemiology, risk factor treatment, and prevention. And I was fortunate that there was a lot of people around me in Uganda who were really enthusiastic about doing this research. And so in the time we have left, I'm going to sort of go through what we've developed. And so the first step was to assemble a research team, including collaborative partners from local hospitals and institutions. I hired a research coordinator in Uganda who was based in Uganda, and I met with the representatives from the relevant ministries, the Ministry of Health, the Ministry of Education, and the Ministry of Labor and Gender. This is my research team, which includes a couple orthopedic surgeons, Dr. John Akure and Moses Muhumuza Fisha, Olive Kobasenje, who's the Senior Research Fellow at the Makerere University School of Public Health, my research coordinator, Daniela, here, social worker Harriet, physical therapists, which include Elizabeth, Anthony, and Francis, a couple other general surgery colleagues, because they actually do a lot of the gluteal fibrosis work in Kumi, which is Ruth O'Bicol, and Robert Olopot. This is one of our CBR team leads. His name's Paul Eckelote, and then my mentor and colleague, Dr. Penny. 3 hospitals became my established partners, 2 in Kumi, because that really seemed like the epicenter of gluteal fibrosis in the country. And Corsi Rehabilitation Hospital, which many of you have heard about, that's where our fellowship is based, which is really the one pediatric orthopedic hospital in the whole country. We then I mapped out a general plan for research on a napkin. It was totally on a napkin, you guys, I'm not lying, in the airport one day. And it became the Uganda Post-Injection Disability Prevention and Treatment Program. It just rolls right off the tongue, doesn't it? I'm really good at naming things. This was like sort of me mapping out the early stages. So this was in 2014, I think I wrote this out, and you could see under injection injury, there were already a number of studies that I thought we needed to do. And so in terms of developing a research plan, like what is needed and what don't we know? So there's 4 general areas. We needed to understand the extent of the problem in Uganda, understand the conditions themselves, so their etiology, pathoanatomy, and the range of manifestations that they have clinically, evaluate the current treatment options, and then focus on prevention. So this is sort of just broken down more, right? Like what factors are contributing to the development of the conditions? Are there systems issues that need to be addressed? Are we addressing the problem in a high quality, effective, sustainable way? What do we need to be doing better? What is the post-operative care? All of that. So lots of questions. So then we went into the implementation phase, knowing that we were going to have to adapt as new information was learned. Perhaps other people were publishing on this as well. That's not the case, really. Funding has been a huge issue, making sure that we have continued engagement from the partners in Uganda, and then additional studies. So where did we start? Understanding the extent of the problem. So anytime you're going to study a new area for yourself, you got to do a literature review. And it became very clear that neither of these had very good comprehensive literature reviews in the published literature. We wanted to target sort of the high rate areas to understand the extent of the problem. And for us in gluteal fibrosis, that was really the Kumi area, which is the Teso region, which is the Teso people. And then develop a countrywide study to see if these conditions are actually present all over the country or only in certain places. So this is one of the first studies that came out. So this is a systematic review of gluteal fibrosis and its surgical treatment. Kristen Alves was a Harvard orthopedic resident at the time doing an MPH, and she did her MPH research with myself and Jeff Katz, who was here a few months ago. And this study really just was a classic systematic review, doing sort of mesh terms and looking through multiple databases to find all the relevant studies. And ultimately, with our inclusion criteria, we got down to 18 studies that talked about surgical treatment of gluteal fibrosis. And you can see that sort of the numbers ranged from, we have required at least 10, and they ranged from around that to over 1,000 patients, with the majority of these studies coming out of China and Taiwan, assessing both open and arthroscopic techniques for surgery. Had pretty good outcomes, with about 86% having at least satisfactory outcomes, and the complication rate at the highest was about 10%. So from the literature that was there, it seemed like, this was a pretty well-studied surgical intervention in those particular countries. There was only one study out of Africa that was by my friend John Akure, and it was only 3-month follow-up, and it was of a small group of patients. So we knew we needed to do more. In terms of post-injection paralysis, so this is an in-process scoping review. We looked at 720 abstracts, 138 underwent full text review, and we're in the process of doing data extraction now. This was Claire Donnelly, who was our IGOT fellow a few years ago, who's now a Yale orthopedic resident. Miss Kyra Robinson, who's in the room with us today, is going to be taking on this project over the summer as part of her Nth Dimensions summer internship. So then we again needed to look at sort of epidemiology, right? So we did a retrospective chart review of the clinical and surgical cases that were at this hospital in Uganda over a 3-year period, looking both gluteal fibrosis and post-injection paralysis to understand the burden of disease. And we focused on this particular area because it was really a perceived epicenter for gluteal fibrosis. So we found that of the 1,035 children that were seen in musculoskeletal clinic, 11% of them had post-injection paralysis and 13% of them had gluteal fibrosis. And of those seen in community outreach, because they do community outreach there, they go to all the different villages and see all the kids and encourage families to bring their kids in for review, because otherwise children with disabilities are not brought to care very often, because there's a lot of shame around disability. So 7% had post-injection paralysis and 29% had gluteal fibrosis. So if you look at this total, 20% of the hospital clinical visits and 30% of the outreach visits were because of post-injection paralysis or gluteal fibrosis. And this is another study then that compared that to the sort of more commonly expected orthopedic conditions in children. So you had 41% iatrogenic injury if you added fibrosis and post-injection paralysis, and then all of the common orthopedic things, infection, trauma, CP, clubfoot, and angular limb deformities being a much smaller contributor to the musculoskeletal burden of disease than those iatrogenic injuries. A third study then is one that got stalled due to COVID, but this was a community-based survey that I developed using a cluster sampling technique, where we had a group of CBR team workers who were going to go around to 100 local schools throughout the country and examine all of the primary school grade level kids to see if they had post-injection paralysis or gluteal fibrosis. And then to have village health teams do random sampling of homes, because again, many of the children with disabilities are not actually sent to school. So in an effort to not underreport the numbers, we are going to do both. And so the gluteal fibrosis is being assessed just by a squat test, because that's how you can tell if they have gluteal fibrosis or not. And then post-injection paralysis is just an examination of gait in their foot and asking them if they had that at birth or if it was acquired over time, because that will distinguish it from clubfoot. This got stalled due to COVID, but we'll come back hopefully soon. So that's really where we started in terms of understanding the extent of the problem. And when we do that countrywide sample study, that will really tell us sort of the epidemiology of the problem in Uganda. And that can be extrapolated to sort of more of East Africa, which also has no data on these conditions. So then we set off to understand the sort of conditions themselves, looking at the pathoanatomy, the cause, the factors, and any systems issues. So this was a qualitative study. So the first one that I've ever done in the orthopedic realm, looking at injection practices. So why are all of these injections given? What is sort of the explanatory model of gluteal fibrosis and post-injection paralysis amongst the healthcare folks in the country? And so this was a 68 key informant interviews in Kumi, which again is that hotspot, in Wakiso, which is where the capital is, focused on injection practices, gluteal fibrosis, and post-injection paralysis. And we really identified 6 themes regarding these conditions and why they're happening. And so really we found that there's poor access to medications and qualified personnel. There's a lot of these private clinics that are staffed by under or not even trained practitioners. So there's like lab techs or like not medical people at all giving injections. Sometimes the pharmacist gives injections or the pharmacist's wife gives injections, none of whom have any medical training. There's a lot of misaligned economic incentives because the private clinics can charge more for injections, so they encourage people to get them even though they're not necessary. The bioavailability of quinine is as good in PO or PR form as it is in intramuscular injection and has none of the health risks. There's a lack of training of people, a lack of regulatory enforcement, limited community awareness that there's a difference between a physician and a nurse versus this person in the lab who has no credentials, and trying to educate the population about where they should be getting their health care and where they shouldn't is really important. And then again, I mentioned before that the parents often prefer the injection over the non-injection because they perceive that since it hurts more, it's stronger, and therefore it will be more likely to save their child. And so they pay extra money for the thing that's actually harming their child. In terms of systems issues, so we're really looking at sort of issues that affect decision-making for treating malaria, why certain medications are given and why they aren't. And so that's a whole nother qualitative review that also is delayed due to COVID, but we're starting back up again this year. And that will also be key informant interviews of parents looking at why we're not malaria testing, or if we are, we don't believe that the malaria test is negative. And so then we're still treating kids even though they don't need treatment. And again, why injections are favored over non-injections. And then really to look at what the mechanism is for why this is happening. So this was particularly interesting to me in terms of quinine, since everybody blamed it for the gluteal fibrosis. And that led to this study which was the one and only basic science study I've ever done in my life. And thank you to Dr. Feely for this. So this was a cell model study looking at fibrogenic adipogenic progenitor cells. And we basically bathed the cells from Brian's lab in culture media with different concentrations of quinine. We actually used some other medications too, but those ones were not, we couldn't assess those at the end of the study. And we basically looked at what quinine did to these cells differentiating filament production. And we found basically that quinine actually upregulated TGF beta regulation, inducing fibrogenesis, and downregulated the BMP regulation, which really resulted in reduced stemness. So we found that quinine itself potentially is contributing to fibrogenesis of the muscles. And so really the next step would be comparing quinine to other commonly injected medications to see if quinine itself is the problem or if it's something more than just the medication. And again, thank you to the Feely Lou lab for allowing us to be a part of that or to use their lab for that study. There is another study that's in the works, a case control study comparing children with post-injection paralysis and gluteal fibrosis and healthy controls, really to see what the exposure history is and to assess risk factors for the development of the conditions so that we can then intervene and prevent future cases of this. And then this, there's, like I told you, there's very little about post-injection paralysis, despite it being a pretty common condition around the world. So this study, which is a little bit on hold, was a cross-sectional study of 30 children with post-injection paralysis at 2 different hospitals in the country, and really looking at their injection history and the time course of the onset of both foot drop and disability, their clinical exam, because again, there's sort of varying degrees of involvement depending on how much of the sciatic nerve got injured. And again, that injury is either from direct inoculation into the nerve, or probably more commonly is just the injection of a neurotoxic substance near the nerve. And then we'll get x-rays of all of their feet and have a standardized quality of life questionnaire. And the hope of this study is that to, one, better characterize the range of manifestations of post-injection paralysis, and also to develop a treatment algorithm, which we will then follow up and study kid with a post-injection paralysis. You can see the extent of the deformity there, and that's not even a severe case. This study, which I was Noma Oji, who just graduated and went to HSS for orthopedic residency, was doing this study with me, but we got a little delayed due to Ebola. Yes, never a good thing. We had an Ebola outbreak in Uganda from October to December. And so that was when we were actually going to do this study. So Ebola thwarted our work. So the third stage is really evaluating the current treatment options. And so this is a study that CU Song, who just also graduated and has gone into plastic surgery, so UCSF student. This was a retrospective cohort study where we looked at all the kids with PIP who were at Horsey Rehabilitation Hospital over a 6-year period that were treated surgically. So not that came with PIP, because that number would be actually astronomically greater, but those who were severe enough to actually need surgery. We found that there were 402 patients treated with surgery during that 6-year period at this hospital. So it's about 69 patients a year. And this is a heat map showing where they were coming from. So you can see that it's actually a pretty extensive distribution. And this upper area here is the Karamoja region, and they probably have post-injection paralysis. They just are really far away and very under-resourced, so it's hard for them to come for care. But I imagine if they had better access, that we would probably see a significant number of children from that area having post-injection paralysis as well. So a bit more boys than girls in this, and the age of first operation, you can see, is sort of distributed over those first 17 years of life, with the average surgery really at around 9.5 years of age. 326 of the kids only had 1 surgery, 63 had 2, and 13 kids had 3 or more surgeries. And we looked at sort of physical therapy and brace use and complications and all of that. We also tried to ascertain the indication for the injection that led to the foot drop and therefore the deformity. And you can see that the majority were a febrile illness, which again, fever equals malaria in a place where malaria is endemic. So that was presumed malaria versus an actual diagnosis of malaria. So more than 70% of the kids had malaria or were being treated for malaria. And then a much smaller number for immunizations. Again, that needle is usually much smaller for an immunization and doesn't go so deep, so unlikely. But when you have very poorly developed buttock muscles in the setting of malnutrition, that nerve is not very far away from the skin surface. And that's probably why we're seeing so much post-injection paralysis. When you look at the surgical conditions that these kids had, the majority of them had just an tendo Achilles lengthening because of a equinus. and then a sort of smattering of other things. Unfortunately, a significant number have triple arthrodesis. And that's one of the reasons why I want to do that pathoanatomy study that I told you about, because I'd like to move us away, ideally, from doing triple arthrodesis in these kids and try to develop a better surgical algorithm to take care of them and ideally give them a much more functional foot than what they have now. So this study really helped us to better understand the burden and character of post-injection paralysis in Uganda. We found that over 400 children were surgically treated for this preventable iatrogenic injury at just one hospital in Uganda. That the kids were from all over the country, so this not an isolated problem. And we really need to improve our treatment algorithms and study them prospectively. So, and this gives us some information on how we can prevent future cases. That group of kids that I saw in 2013, we then found in 2018. This was one of the first studies that I did over there. That's Amanda Riley, who was a UCSF student who graduated a couple years ago. And this was a 5-year follow-up on that first group of kids that I saw running in the field playing soccer. So they had come for a surgical camp that week. We found them 5 years later. We did in-home and in-school assessments of their range of motion and function and their scar satisfaction. We found 75% of the kids, which is pretty cool. And some of them had really good preoperative measurements and some of them didn't, depending on which physical therapist saw them. So for that subgroup with really good preoperative measurements, we were able to do some good analysis. And then we also did this sort of functional assessment of their function. And so what we really found here is that over that 5-year period, they had a significant improvement in their ability to run, sit up in a chair, sit at a bench, use the toilet, eat while sitting, which again, you wouldn't think that that would be such a hard thing, but this way they didn't have to lay down anymore or stand up. They could actually sit down. They could go to school and they could do PE. And that was a sustained benefit over the 5 years. This is still a problem, in case you thought maybe this had gone away. In January 2020, right before the pandemic, we did a screening of over 160 kids. 112 of them had moderate to severe gluteal fibrosis, and 109 of them had surgery. And this was a study, which we'll talk about in a second, but really a greater understanding of the severity of symptoms and impact on quality of life. Again, this was actually a family of 3 sisters, all which have gluteal fibrosis. And again, that lower left picture shows that even when sitting sideways, they can't sit up, so they fall over. Countless pictures of that. And the manifestations of the buttock atrophy can be, anything from sort of mild with just a bit of a crease to multiple areas of dimpling, and then significant atrophy of the buttock muscles that you see there with all these sort of pocks and dimples, and the soft tissue really fixed to the deeper layers. So we did a surgical camp, which was no expense to the patients or the hospital. We had a local surgical team doing the surgeries. And because this is surgical grand rounds, just wanted to show you some pictures. So although that looks like something like that might be an actual anatomic structure, that is just fibrosis. And so this is a release of it's just posterior to the greater trochanter that the muscles are released. Once the release is done, you release all the way down till you basically get to the perineural fat above the sciatic nerve. And then you do, oh no. This is the most important video. So then you flex, internally rotate, and you let it go. Rosie missed that. Rosie missed it. She turned around right at that moment. And it makes a horrible sound. And the first time I saw this done, I thought it was a femoral neck fracture, but alas, it was not. And that's truly a release of the soft tissue, and then with the cautery, and then an forced internal rotation and adduction move, and the fibers release, and they have a marked improvement in their range of motion. It is a terrifying surgery to watch, though, and to do, by the way. And every time I fear that the neck is not going to survive. But that's why there's not a lot of great treatment options for people who are not children, because you wouldn't want to risk the neck in those people. So what do you do for the adults that have this condition? So this is a prospective study. This one also got a little bit thwarted by COVID. And so we'll do 4-year follow-up of those kids instead of the 2-year follow-up that we had planned for. And really, there's a lot of studies that are in the works. So that PIP pathoanatomy study looking at treatment for kids with both conditions, physical therapy and bracing, the role of physical therapy in mild forms of both of these conditions, nursing education and practice intervention, and then implementation of prevention interventions. So there's still a lot to do. We still don't totally know the causes of these, both direct and indirect, and what treatments are best for those who are already injured, and how do we prevent others from being injured. And that really gets us into the final step, which is the advocacy phase. And so we have done some work around advocacy and education. So the top is an article out of one of the national newspapers in Uganda in 2019. That's actually one of the guys from the hospital that I work at, sort of presenting our work to some folks from Italy and some of the ministers of health in the area. So we did get some press on this. This is a podcast that I did out of South Africa talking about injection injury. We presented at the College of Surgeons of East Central and Southern Africa, as well as working with the Orthopaedics Society of Uganda right now to do a whole advocacy program to the Ministry of Health, as well as including a group of pediatricians in that as well. However, there are a number of challenges. So actually our testinate just got, the malaria, the falciparum in Uganda now has some resistance to the artesunate derivatives. So they're actually encouraging quinine to come back, not to go away. And that's a problem. And then certainly COVID and Ebola and other infectious diseases sort of always reign supreme over some of these more chronic problems. But there's also some potential opportunities for change in the future, including the introduction of a malaria vaccine, which is being tested in a couple countries in Africa right now. So there's a lot of work to do. That's what we've been able to do so far. Again, just want to acknowledge the people that I work with in this work, which are all listed there, both on the Uganda side, as well as colleagues from here and the medical students that I've had the pleasure of working with over the years. And then my partners here who allow me to do this work, the incredible staff at Oakland Children's who takes care of my patients while I'm away, our department, IGOT, Brian and his team for that study, and then my colleagues at CHESA. And thank you.
All right. Thank you, Dr. Sabatini. That was amazing and very impressive work. And I think we're right at 8:30. I see Alex's hand up. We might have time for one quick comment question. Got it.
Ooh, that was a good catch. Yeah, no, that's a great question. So once the injections are given, the damage is sort of done, right? So if, for example, post-injection paralysis occurs, the intervention then would be to get that identified and into care as soon as possible so they can start physical therapy and bracing so that we can prevent the deformity. That's sort of the biggest thing that we can do there. But really, there's not we've kicked around the idea of, is there medical management of this fibrosis, right? So there are drugs that can be given for other forms of fibrosis, and certain populations here are more susceptible to cardiac fibrosis and urethral fibrosis, the same group that has all this gluteal fibrosis. So is there a way to medically, intercede on this and sort of avoid surgery? And that's a question that we're trying to figure out. Really, if we could just reduce the number of injections being given, and for those that are being given, have them given in the right place and avoid certain neurotoxic medications, that would be the goal.
Drew said one last comment, but I have to just say, it's just wonderful to watch your ascent. It's just inspiring.
Thank you. I appreciate that. Thank you for facilitating it.